So I'm the first presenter as well, so we'll just continue with some antimicrobial stewardship updates for the state of Nebraska. Okay, I have no relevant financial disclosures. So I wanted to provide first an overview of the antibiotic stewardship practices in our state in the different settings. So I know you're all from different settings here today. So first we'll talk about hospitals, then long-term care, and finally outpatient. Next, I wanted to talk about our role as public health and stewardship and how we can help to collaborate with you. And then finally, I want to leave you with some resources that you can use year-round. So not just today at the conference, but when you return, so you have some references that you can use as you work on your stewardship practices. So we'll start today with hospital antibiotic stewardship. So I always want to start with the CDC core elements of antibiotic stewardship. If you've been practicing for some time, you're probably very familiar with these, but if you're new to stewardship, this is a great place to start to really understand what a stewardship program should be. And there are 7 core elements for most settings. So I would recommend that you read the document that's specific to your practice settings. They have published guidance for hospitals, critical access hospitals, long-term care facilities, outpatient, and some others. But the 3 foundational core elements are leadership, support, accountability, and drug expertise. This is really the foundation of your program and really sets up the ability to do the stewardship work from a day-to-day basis. The other 4 core elements, action, tracking, reporting, and education, represent that continuous quality improvement process that we should be repeatedly doing over and over again as we identify issues with stewardship in our facilities. And so really all 7 of these core elements have to work together. If you're only meeting 3 or 4 of the core elements, you can imagine you don't have necessarily a fully functional, strong stewardship program. And so one of the ways they track how well stewardship is kind of doing in your state and throughout the country is to see how many of your hospitals are able to actually meet all 7 of these core elements. This was first published in 2014, and you can see at that time only about half of the facilities in Nebraska that reported, so only 14 hospitals were meeting all 7 core elements. And these are mostly our big hospitals in the state. Fast forward to 2022, we have 88 hospitals reporting, and 93% of them are meeting all 7 core elements. So this is some major progress in our state, and I'm very proud to see this over the years. Because most hospitals in the country have met all 7 core elements, the CDC in 2022 published these priorities for hospitals to work on then. And so there were 6 priorities for 6 of the core elements. And these are kind of more specific activities that have been shown to have improve your stewardship outcomes. And so we'll look at those a little bit more in depth here. So as we saw, 93% of the hospitals in the state met all 7 core elements, but when you look specifically at these newly published priorities, we see far less of our hospitals able to meet all 6 of these. In fact, only 2 hospitals in the state. And so this is not really surprising since these are new and they're kind of complex, but I think this just identifies we have some opportunity to kind of specifically hone in on some of the activities we can do in our hospitals to improve stewardship. So looking a little bit further at these and how our hospitals are performing, the first priority is that for leadership support, that the physician and or the pharmacist in charge of stewardship has antibiotic stewardship job responsibilities actually written into their job description. And so we see about half of our hospitals have taken the accountability for the leadership of the program to this hospital, and this is pretty closely in line with the rest of the country. The second one for accountability is that the program is co-led by a physician and a pharmacist. And again, about half of the hospitals in our state have implemented a co-leadership program. When the core elements first came out, it seemed like the responsibility to lead the program was largely put on the pharmacists, and I think that's kind of where it's stayed ever since. And so they're really kind of trying to promote the physician, get more involved, not just showing up to your committee, but taking some leadership accountability to co-lead the program. So I think we have a ways to go there. The third core element is drug expertise, and they recommend for the priority that your leader of your program have specific training in infectious diseases, whether that be formal through a residency or fellowship, or more informal through like an online certificate program that you can do on the job. And so we see about 3/4 of our hospitals in the state have at least provided their leader with some opportunity to get some specialized training. The fourth priority core element has to do with the action, which is that the facility has implemented hospital-specific treatment recommendations and they perform prospective audit and feedback. So I think it's encouraging to see that 62% of our hospitals have done these two high priority items. And again, this aligns pretty closely with the country, which is about 72%. The fifth priority core element, I think, is where we've made the most progress in our state over the last year, to where we're about 50% of our hospitals reporting their antibiotic use to the NHSN module. In 2022, this was only 16% of our hospitals. So we've made a huge leap here. And then finally, the last core element, priority, has to do with tracking. And it's that providers are given annual feedback reports, specifically on their prescribing practices, and that the hospital is monitoring adherence to the guidelines they published. So are the providers actually doing what you're suggesting as a hospital? This one's really difficult to do. It's really hard to generate these provider-specific reports. And I think that's reflected in how many hospitals are able to do it, only about 1 in 4 in our state. So again, just priorities and things to work towards in the future. So as I mentioned, reporting antibiotic use to the NHSN module has been a piece where our hospitals have made a lot of progress over the last couple of years. This has to do in part with CMS making it a mandate for the Promoting Interoperability Program to start reporting this data. But I think our hospitals have done a really great job in implementing this, and we've really made faster progress than a lot of other states. And our state health department has really kind of been a resource to other states as well into helping like hospitals in Kansas and Iowa try to implement as well. So I'm very proud of the work that's being done here. And why that's so important is so that we can see from a state perspective how we're using our antibiotics in our state in our hospitals. So what you're looking at here, every red dot on this chart is a different hospital in our state, and this is their SAR distribution, so their standard antibiotic administration ratio. If you're an infection preventionist, this is kind of equivalent to the SIR, if you're used to seeing that number. But anything over 1 means you're using more antibiotics than expected. So these hospitals at 1.1 are using 10% more antibiotics than would be expected based on their risk adjustment. The hospitals with less than 1 are using less antibiotics than is expected. So this is interesting because in infection control, our goal is 0 hospital-acquired infections, right? We want 0, but we'll never use 0 antibiotics. That's not the right thing to do either. So really this is trying to kind of find some middle ground of like what is an appropriate amount of antibiotics that we would expect to be used. But I do always want to caution people when they're looking at this SAR is that this is not a measure of appropriateness of antibiotics. All this does is point you in a direction as a stewardship program that you might need to investigate if you have a really high SAR and see why are we using so many different antibiotics. So we do see that there are a couple outliers in our state that are using 30–40% more overall antibiotics than is predicted. So I think, again, there's some opportunity there to investigate. And maybe even on the other end too. If you're using 40% less antibiotics than is expected, is that appropriate too? It just kind of gives you an idea of places to look. Another thing we can get out of NHSN specifically is for which antibiotic, how much are our hospitals using? And this is really important as we start to see resistance develop across our state. So ceftriaxone in particular, we've seen across the state that more and more resistance is developing, and it's very worrisome because that's kind of our big gun frontline thing that everyone gets. But we see also from looking at this, there's a huge disparity in how our hospitals use their ceftriaxone. Our lowest third of hospitals use 44 days of ceftriaxone for every 1,000 patients they have in their hospital, and our highest use 203. So they use 5 times as much ceftriaxone. So again, not necessarily a measure of appropriateness, but I think it really highlights, especially when we look at the highest 3 hospitals across these different antibiotics, they tend to kind of be the same facilities over and over again. So I think we have some good opportunity to provide some education and guidance here. One thing I will caution you, if you're manually tracking your antibiotic use as days of therapy per 1,000 patient days, that number does not compare to this number, so please don't, if you're manually tracking, please don't compare them. They're different denominators, so these numbers kind of only compare if you're using NHSN. Okay, so now let's transition into long-term care antibiotic stewardship. So again, the 7 CDC core elements are really how we measure how successful our antibiotic stewardship programs are, and there are the same exact 7 core elements in long-term care as there are in hospitals. They were published 2 years later than the hospital core elements, kind of based off the success of the hospital core elements. So in 2016, you can see only 1 in 5 of our nursing homes were able to meet all 7 core elements. In 2017, CMS made it a mandate to implement an antibiotic stewardship program in your nursing home. So we saw a huge jump of people starting to work more on antibiotic stewardship. And it continued to increase over the years. However, what we didn't see in hospitals was this huge dip during COVID, but we did see a huge dip in our long-term care facilities with their ability to do antibiotic stewardship during COVID. So I'm thankful to see in 2022 that not only do we have a lot more long-term care facilities completing this annual survey and reporting this, but we're seeing a pretty good increase in work being done in antibiotic stewardship. So about 3/4 of our nursing homes say they're meeting all 7 core elements. One thing we've identified at the ASAP program was that one of the core elements in long-term care that seemed to be struggling the most was drug expertise. The core element states that your long-term care facility will establish access to a consultant pharmacist with experience or training specifically in antibiotic stewardship for your facility. And there really wasn't a way for consultant pharmacists to access specific training in long-term care for antibiotic stewardship. There's a lot of antibiotic stewardship training programs out there, but they weren't really intended for that specific audience in this specific setting. So we partnered with UNMC ID Project ECHO and the Nebraska Pharmacists Association and recruited 37 pharmacists to do a year-long training program with us. So we're well on our way into that now. So if you haven't been talking with your consultant pharmacists in long-term care about stewardship, chances are they've learned a lot over the last year. It's been a good collaborative, so they may be a good resource for you to access. So I want to finish up long-term care by sharing, I think, one of a really good success story about how long-term care can interact with public health. So in 2020, when the first therapeutics for COVID became available, they were mostly being sent to the hospitals. The people in long-term care, the vulnerable populations that needed them, really didn't have access to them. They weren't being shipped to them. They didn't have anyone to infuse them. Our State Department of Health and Nebraska ASAP identified that as a huge issue and a way we could prevent a lot of hospitalizations if we were able to get these treatments to long-term care. So we developed an online survey where any facility in our state could request that we review that resident for treatment and then actually provide the therapeutic directly to their long-term care facility. Importantly, we also provided a hotline where any nursing home in the state could call and actually talk to an ID pharmacist or an ID physician and get their questions answered. What drug should we use? When should we give it? Is it too late to give it? Are there drug interactions? All of these different things, we made a specialist available to our providers in long-term care. So did it make a difference? And we see that it made a huge difference. In 2023, McGarry et al. Published some nationwide stats on how therapeutics were used in long-term care from May 2021 to December 2022. So when we had a pretty high burden of disease. And only 60% of skilled nursing facilities in our entire country gave a therapeutic to a resident ever. So 40% of our nursing homes in our country never gave a therapeutic to any of their residents, ever. In Nebraska, we had 77% of our facilities at least give one course of treatment, which ranked us 8th nationally. So that's really high, and I think it was reflected in our being one of the lowest states with resident deaths from COVID early on in the pandemic. And then also we see that throughout the pandemic, our average percent of residents that got treated was 35%. The peak nationally was 33%. So we did better every single month through this whole time in getting treatments to our residents in Nebraska than the country did at their highest, best month ever. So I think that's a very, very good success story, I guess. So during that specific short time frame, ASAP helped deliver over 1,400 therapeutics to residents in our states and hopefully kept a lot of our long-term care residents in Nebraska out of the hospital and also prevented hopefully some mortalities. Overall, this was a short time frame we looked at because it matched up with that national study, but overall, ASAP delivered almost 3,000 therapeutics throughout the state in conjunction with Consona's pharmacy. So again, I think a really good success story there. Okay, so the last area we'll touch on is outpatient antibiotic stewardship. I'm not going to talk a whole lot about this because we actually have a whole breakout session that Dr. Kainz on our team is going to have later this afternoon. So if you're signed up for a different one, like I said, they're going to be recorded so you can watch them later. But I do think it's really important to touch on. So as much as we work with our hospitals and as hard as we work on our hospitals about antibiotic use, they only use about 10% of the antibiotics that go out in our state. The other 90% volume-wise is used in the outpatient setting. So this is a huge area we need to address for antibiotic stewardship, but one that comes with a lot of challenges as well. So just to orient you to this, the numbers on this graph, the red bars for Nebraska represent how many prescriptions were written per 1,000 population. So in 2019, that 920 prescriptions per 1,000 populations means we wrote enough antibiotics prescriptions in the outpatient setting that 9 out of every 10 people that live in the state could have got a prescription. So even looking around this room, that's a ton of antibiotics. It's crazy. So we did go down a little bit during COVID, but so did the rest of the country. But we do see it kind of starting to increase again. And so year over year, Nebraska remains kind of one of the highest prescribers in the entire country. In fact, we rank 8th in the highest prescribing state. And so again, just I think identifying this as an opportunity to do some work in the outpatient setting, especially when we see our neighbors in Colorado only use 400 prescriptions, so only 4 out of every 10 people get treated. So what are they doing? I guess that they use half as much antibiotics. So again, good opportunity here, and we're starting to try to expand our ASAP services into the outpatient setting as well. Another data set we were able to get access to was CMS Medicare Part D prescribing data for beneficiaries in Nebraska. And so we see there was a significant, statistically significant difference between our rural prescribers and our urban prescribers, though when you look at it, the difference really isn't huge. But again, I think this just identifies another opportunity that our rural prescribers maybe need some more resources, and so how can we find a way to reach out to them as well? I know we have a lot of people from rural areas attending today, so thank you for coming. Your help is very much needed. So. Okay, so now we'll transition into public health antibiotic stewardship. So again, going right back to those CDC core elements of antibiotic stewardship. And these are all the different iterations that are for all of the different healthcare settings where you guys practice. But in 2023, the CDC also released core elements for health departments. And so now us at the state health department are kind of being held to the same standard as all of you out there practicing. We have our own 7 core elements, but you'll see they also align almost exactly with everything you're doing in your healthcare facilities. So really this is pushing state health departments to be more of a resource and be more accessible to facilities if they need help. So doing things kind of like today with the tracking and everything and sharing that with you all as well. I guess one of our goals today is that you could meet some of us in person and know that we're accessible to you. So if you ever need anything related to your stewardship program, you are able to reach out to us. So most of the people you see up here are either speaking or moderating today or will be out at the table. So if you'd like to, please stop by, introduce yourself. And we want to be able to help you in any way that we can. One of the main ways we help facilities is through these antibiotic stewardship program assessments. And so these are just self-assessment surveys we've built for the 3 different practice settings you see here, hospitals, long-term care, and outpatient. These are non-regulatory and at no cost. They take about 15 to 20 minutes to fill out, and it really just walks through the 7 core elements for your specific setting and asks some specific questions about activities that you may or may not be doing in your facility. And so I think this is a good activity you could do at your stewardship committee meeting, maybe once a year, and just kind of see how you're progressing through your stewardship program. And then if you're interested, our ASAP team can meet with you one-on-one either through Zoom or we'll come on site to your facility and just kind of talk through for about an hour, just kind of what you've answered on here and see if you can provide any resources or guidance for you. And kind of new this year, like I mentioned, we're starting some more efforts in outpatient, so we've added an outpatient assessment. So if you're a hospital with maybe a bunch of clinics associated and you want to pass this along to your clinics, that would be great as well. And then another opportunity you have to interact with us is we actually have an advisory council for the state health department related to antibiotic stewardship. So as of right now, we meet about 3 or 4 times a year and have people from different settings, different organizations on this committee. And really they kind of just share with us what's going on in their facilities so we can see where we need to allocate more resources or provide more assistance in certain areas of the state. So if you're interested in joining this committee or participating, please just let me know. And then kind of the last thing I wanted to mention, I think for hospitals specifically, is that for the NHSN AUR reporting implementation, we have received a grant from the CDC to help reimburse some of the expenses related to this. It's a very expensive endeavor, especially for critical access hospitals. It's a pretty good chunk of change to get this implemented. We've reimbursed 11 hospitals in our state so far, almost the full cost of implementing this. And so we do have about another year left on this grant. So if you've recently started reporting to NHSN your antibiotic use and resistance data and you want to apply for this, please just reach out and let me know. Otherwise, the link is here. And then another thing that we're doing is that for any hospital that's started to report their antibiotic use data to NHSN, we've compiled a state report for your hospital specifically that we'll be sending out hopefully in the next couple of months. But what's nice about these is that NHSN provides a national benchmark so you can kind of see where you fall nationally. What we've been able to do is compile specifically here in Nebraska how you're doing, and we can provide you some comparison. And we've further broken it down per request from some of our hospitals to critical access, specifically medium-sized hospitals and large hospitals. So you're able to even further compare where you lie compared specifically to other critical access hospitals in our state or other large hospitals in our state. So I think that data can be really helpful for your program as well. And then lastly, we want to invite you to participate in U.S. Antibiotic Awareness Week that happens every single year in November. The CDC puts out a partner toolkit about September every year that gives you a whole bunch of flyers, posters, things you can post on social media, and things you can do so you don't have to come up with these things from scratch. But it's really a big initiative that we try to promote at the state health department, and so I think promoting it through your facilities. I know we had one of our local health departments did a radio ad and a billboard last year, which had some great interaction as well. So that's a good way that you can meet some of your core elements and participate in antibiotic awareness as well. Okay, so lastly, I will leave you with some of our ASAP resources we've worked really hard to develop in hopes that they can be helpful to you. First is our website. Hopefully you've seen our website or visited it, but we do try to add new stuff to it quite a bit. And then we also have a YouTube channel, which has 93 videos on it right now, including all of the previous summit videos. So you can use those at any time. I get approached sometimes from hospitals wanting us to provide more education to their providers. And I think this is just a wealth of good videos that a lot of them are specifically made for Nebraska, so that you can use them for some education in your facility. New this year, we've also created a Nebraska ASAP newsletter called the Antimicrobial Advocate. So this comes out monthly through email. If you're interested, we have about 250 people signed up for it so far, but if you want to be added, you can just subscribe on our Nebraska ASAP website. And then finally, we also have a pretty active social media page. This can be really helpful. We try to watch out for like webinars or state meetings or new guidance that's come out, and we try to keep it updated. So this can help you kind of keep a pulse on things a little bit easier on what's going on in antibiotic stewardship and infection control as well. Here's a picture from some of our team on one of their road trips. So that's all I have today. Again, I just want to thank you all for coming, and I'm excited to see what the rest of the day holds. Thank you.